Hi, I'm Dr. Katie Amaodeo, and I am a neurologist who specializes in movement disorders. At this time, I am practicing in the Hudson Valley area of New York under Westchester Medical Center, alternating between sites at Westchester and up in Poughkeepsie at Mid-Hudson Regional Hospital. And I primarily manage and treat patients with Parkinson's disease and dementia with Lewy bodies. And today I'm going to be presenting something that we're very excited about called DIAMOND Lewy, I'm presenting a US-based DIAMOND Lewy toolkit, a cheat sheet on medical management for those with Lewy body dementia. These are my disclosures. I do serve as co-chair of the Lewy Body Dementia Association Working Group on Clinical Care and Professional Education. I have served as medical monitor, principal investigator, and co-investigator on several clinical trials, and my fellowship training was funded by the Edmund J. Safra, Michael J. Fox Fellowship Foundation. An outline for today's talk. So what I'm going to start with, I'm going to give a brief background about Lewy body dementia, what we mean by this diagnosis, key symptoms of the disease, which will then lend itself to my discussion on the US-based DIAMOND Lewy toolkit that gives expert consensus on the medical management for symptoms of Lewy body disease and dementia. These guidelines, again, are based on expert consensus among experts in the field. Particularly, we worked with our colleagues in the Lewy Body Dementia Association working groups. And this was adapted with permission from the DIAMOND Lewy toolkit that was created in the UK, which is a fabulous resource. And they kindly allowed us to adapt it to the US-based system, primarily, making changes to acknowledge, our differences in perhaps healthcare systems, what's on formulary, what's FDA approved. And so we got together and made those adaptations. And we're presenting those to you today. So just a brief overview. Lewy body dementia, when we say that, what do we mean? It's an umbrella term to include Parkinson's disease with dementia and dementia with Lewy bodies. They are both neurodegenerative diseases involving the accumulation of abnormally folded alpha-synuclein in the neurons of those impacted with these diseases, and they form Lewy bodies, which is shown here. That's what you would see in the pathology, the microscopic pathology in somebody impacted with this. And they share that Parkinson's disease and dementia with Lewy bodies. When we talk about Lewy body dementia, there are these key diagnostic features that aid in diagnosis. And a patient may not have all of these, but the presence of dementia, so what that means is cognitive impairment that's global across several domains, that's impacting one's function. It's been gradually progressive. Coming along with two of these features, whether they be cognitive fluctuations, Parkinsonism, which when I say Parkinsonism, we mean the motor symptoms of rest tremor, bradykinesia or slowness of movement, rigidity or stiffness, and postural instability, the propensity to fall. Visual hallucinations, so seeing, overt visual phenomenon, a person, an animal that's not really there. And REM behavior disorder, the propensity to act out or enact one's dreams. When we're in the REM stages of sleep, those of us not impacted by one of these, by Parkinson's or dementia with Lewy bodies, we would not act out our dreams. We have atonia. Those who are at risk for this disease or who have these disease, Lewy body dementia diseases, actually enact one's dreams, and it's called REM behavior disorder. So again, these are the key diagnostic features of Lewy body disease and dementia, but you don't have to have all of them, okay? But when you see these, be thinking about this in your diagnosis. There are supportive features that can also aid in diagnosis. They're not considered the core features, but they are supportive. So when you see, the core features coming along with these other symptoms, again, be thinking about Lewy body. So that could be non-visual hallucinations, tactile, perhaps feeling things that aren't there, auditory, hearing things that aren't really there, delusions. They're often delusions of spousal infidelity, but they can be other, paranoia flavor as well. Propensity for syncope, often due to the autonomic dysfunction that we see in these diseases. So orthostatic hypotension being a common manifestation of autonomic dysfunction, that propensity to your blood pressure to drop upon standing, which can lead to syncope. When you're hearing about falls, again, that postural instability should be, a clue to you in somebody with dementia. The autonomic dysfunction can be varied. It can include constipation, urinary retention, propensity for sweating, runny nose, tearing of the eyes or dry eyes. Loss of sense of smell, we call that anosmia. And that is something that can occur years before the onset of the cognitive or motor features. And then hypersomnolence, or increase in daytime sleepiness. These patients impacted with this disease can sleep for up to 15 hours or more a day, including sleeping at night. So there's hypersomnolence. And then we know that mood disorders are common, not just a reaction to the disease, but actually features of the disease. Depression, anxiety, apathy, that indifference are common supportive features of this disease. The presence of psychosis, which can include hallucinations and delusions, can vary in presentation, as we talked about. They're often well-formed visual hallucinations, and that's considered a core feature in diagnosis, but it doesn't have to be that. Sometimes it can be auditory, hearing music, hearing dogs barking that aren't there. Tactile, feeling something on someone's hands that when really there's nothing there. Olfactory, so smelling something that's not there, which is always a little bit unusual in that they do tend to have reduction in sense of smell, so then they'll smell something that's not really there. And then delusions, and the delusions, like I said, can be often about spousal infidelity, but they can also be other paranoid delusions, like about finances, somebody's taking something from them, and obviously those are very upsetting. I just want to talk a little bit about the differences between dementia with Lewy bodies and Parkinson's disease. But before I do that, I'm also going to talk about what they have in common. So they're shared characteristics. The reason this is important is as we get into the management, particularly the motor symptoms, as I get into that, I just want us to have a little bit of background. So as I said, they fall under the umbrella of Lewy body disease. And when Parkinson's disease, when somebody with Parkinson's disease has dementia, so we call it Parkinson's disease with dementia, we would call it a Lewy body dementia, a form of Lewy body dementia. And dementia with Lewy bodies, again, is a form of Lewy body dementia. They're both neurodegenerative disorders involving abnormal alpha-synuclein that form those Lewy bodies. They both can have characteristic premotor or prodromal features, REM behavior disorder, acting out the dreams. That can occur years before the motor features or the cognitive features start, 20 years perhaps. Anosmia, constipation, so these are symptoms that can occur well before the motor features that characterize Parkinson's or the dementia with motor features that characterize dementia with Lewy bodies. They both can have Parkinsonism, so that slowness of movement or bradykinesia, rest, tremor, rigidity, postural instability, and gait dysfunction. And they both have cognitive and behavioral disturbances. So again, cognitive can be more severe to actually meet a diagnostic criteria for dementia and Parkinson's. And they both can have behavioral disturbances, including hallucinations, delusions. And again, they both have autonomic dysfunction. We see orthostatic hypotension, constipation, that runny nose, and so forth in both Parkinson's and dementia with Lewy bodies. So how are they different? How do we distinguish the two? Here we're really, like I said, collectively calling them Lewy body diseases, but when we think about distinguishing them, it's really based on when the motor features occur in relation to the cognitive features. And so in Parkinson's disease, you're making that diagnosis when the motor features, the Parkinsonism, are the initial presentation. And it's generally in somebody with Parkinson's disease, it's not for years later, after the onset of motor features, do they start to develop cognitive changes, and in some progressing to dementia. Not everybody with Parkinson's will develop cognitive impairment or more severe dementia, but that's something we can see. And over time, again, they may also be at risk for developing psychosis, hallucinations, delusions. That's often already in the setting of being on dopaminergic therapy medicine to treat the motor symptoms. Conversely, we make the diagnosis of dementia with Lewy bodies. We use the 1-year rule. So when there's dementia, so to have dementia with Lewy bodies, you have to diagnostically meet criteria for dementia. So progressive global cognitive impairment impacting one's function. So that's got to be there for diagnosis. And that can be there either before the motor features or within a year, onset within a year of the motor features. So that's the distinguishing feature, right? Is when the motor features are occurring in relation to the cognitive features. The psychosis, visual hallucinations, delusions, are often spontaneous. So meaning they can occur without being on dopaminergic therapy. Often it's an early feature, and they present early in the disease course, as opposed to Parkinson's, where we tend to see that later. So this is, the basis for my presentation today to talk to you about our toolkit, is that the pharmacologic approach in Lewy body disease is challenging. Largely our management is based on expert opinion, which I'm going to be presenting today. There are few clinical trials to go by. We know our patients with Lewy body dementia are at increased risk for side effects. They tend to be very sensitive to medications. And so they're just a more sensitive population. So that's something to keep in mind when you're thinking about management. Low dosages, start low, go slow. Something that I really want to drive home today is that antipsychotics in general are dangerous in these patients. So medicines that block dopamine in a disease where they're inherently deficient in dopamine, it could be very dangerous. There are antipsychotics, quetiapine, clozaril, and Nuplazid, that are safe to use, but all other antipsychotics are not safe. So you have to be cautious. I just talked about psychosis, hallucinations, delusions being a core feature in these diseases. So then how do we treat that? We're going to talk about that. Dopaminergic therapy, while it's helpful for the motor symptoms, can sometimes lend itself to worsening hallucinations or confusion. So again, we have to be cautious. We're going to talk about that. The best data that we have at this time is acetylcholinesterase inhibitors, like donepezil, rivastigmine, to help cognitive function, and there is evidence that can help the psychosis, the hallucinations and delusions. So be thinking about acetylcholinesterase inhibitors as you are thinking about treating your patients with Lewy body, because you can help their cognition and you can help their hallucinations potentially. It may also provide benefit for apathy, that indifference. So this now leads us to, again, the main objective of today's talk, which is to present to you our US-based DIAMOND Lewy toolkit on management in Lewy body disease, dementia. And so why was this created? So we wanted to identify key problems that we encounter in this disease, the cognitive functions, balance trouble, the motor features, hallucinations, these are the key features, and then establish consensus on the treatment, discuss benefits, risk of treatment. We want our audience to be aware that symptom response is variable, and some treatments may lend to global benefits. So we talked about cholinesterase inhibitors. Something for you to, again, to kind of be aware of and take away today is that it can help with cognition. It can also help with hallucinations. So be thinking about that medicine. Again, this was a US-based toolkit, so meaning we we adapted a well-established, carried out toolkit that's done in the UK, that's been looked at with research in terms of making sure that they had consensus criteria, and then we adapted that to a US-based approach with permission. So you can go on our Lewy Body Dementia Association website. You can also Google, DIAMOND Lewy, and what you'll find are different toolkits for you. So the one thing you'll find is an overview sheet. This is a nice quick look at the different, main key features of the disease, and what do we recommend? What do the experts recommend? So let's just say you have a patient coming to you with more psychosis, you can quickly look at this little neuropsychiatric box and see that quetiapine and clozaril are least apt to worsen Parkinsonism. So you might want to think about that if you're wanting to treat with a medication. Something to also point out is that the approach to these symptoms, while we're talking about the medications, highlighted here, medications aren't always indicated. Non-pharmacologic approach may be the right thing too. And so when we think about non-pharmacologic approach, you can try orientation, validation, reassurance. When a medication is needed, particularly in the acute setting, again, you might be thinking more of an antipsychotic like quetiapine or clozaril. But something to think about in your outpatient practice is starting with a cholinesterase inhibitor like donepezil or rivastigmine. So this is a quick sheet that we have to show different treatments quickly. Now, we also have more in-depth sheets for each symptom, each key symptom that I'm going to show you. And then we have a comprehensive Word document, a more comprehensive, where we really go through explanations and so forth and guidelines. So there are different resources available to consult. So I'm going to talk about the cognitive symptoms now. This is the toolkit, the resource you will see that's more in depth for cognitive symptoms. And again, it starts with just general principles, what you might see in somebody with cognitive impairment, meeting criteria for Lewy body. Think about non-pharmacologic approaches. So socialization, cognitive exercises, encourage, staying active and so forth. Exercise being very important. And then when medications are, indicated in a discussion with your patient, and when it's the right thing to do, we talk about our recommended medication approach, which really first line is cholinesterase inhibitors. And then you can consider memantine or Namenda for those who maybe aren't responsive to cholinesterase inhibitors or don't tolerate cholinesterase inhibitors, I should say, either as monotherapy or as adjunctive therapy. And we go more in depth of that in the actual Word document. So cholinesterase inhibitors, like I said, are really the choice, but there are considerations to think about, particularly cardiac side effects. So something to think about, particularly patients with cardiac disease, you might want to consult with their cardiologist and make sure this is okay to start, but it can be helpful. It's the most evidence we have. We have the most evidence for rivastigmine and Parkinson's disease with dementia. There is evidence for glutamine, but donepezil is often the one that we use most often because it seems to be the best tolerated. But again, everybody's different, so I don't want to make a blanket statement about that. And then more in depth in our resource, we'll talk about, how to start the medications, our general approach. You always want to start low and go slowly, and we have those guidelines outlined. Being aware of potential side effects, often GI, bradycardia, slowing the heart rate. You might want to just try redosing, doing a reduction in dose before you completely stop it. Sometimes that's enough to help symptoms. Memantine is something you can consider, like I said, as monotherapy or as adjunctive therapy with those on acetylcholinesterase inhibitors. And you just want to be mindful again of starting low and going slowly. And again, we have this more in depth in our toolkit for you, and that's what's really cool about this. With the motor symptoms, we're going to talk about that approach, and that's particularly why I wanted to talk about the differences between dementia with Lewy bodies and Parkinson's disease with dementia, even though we collectively call them Lewy body disease. This, is one of the areas where that distinction is important, because somebody with Parkinson's disease with dementia likely has been on anti-Parkinsonian medications, levodopa, selegiline, and entacapone already, where you are maybe thinking about starting those medicines in somebody you've just diagnosed with dementia with Lewy bodies because their motor features are impacting them or maybe putting them at risk for falls. Conversely, somebody with Parkinson's disease with dementia, you might be thinking about reducing the medicine because they're having more hallucinations, they're having more confusion, and we know that our medicines can sometimes make those symptoms worse, and so you might want to be thinking about reducing it. And we actually give a little bit of a guideline on how to withdraw the medicines, like in what order to consider. For dementia with Lewy bodies, when we think about treating the motor symptoms, really carbidopa, levodopa is the one that we would use because it's the best tolerated and it's effective. But you would be cautious with this. So you would start at very low dosages and titrate slowly as tolerated, but often using, the lowest effective dose to help motor features, help reduce risk of fall, but not contribute to hallucinations and confusion, which you have to be very mindful of in this population. Again, with all of our symptoms that we're talking about here today, there are the pharmacologic approach and then the non-pharmacologic approach. And so you want to be thinking about physical therapy. Is there anything that's maybe worsening their motor symptoms? Did somebody start an antipsychotic perhaps? So always look at the medication list. So again, antipsychotics are dopamine blocking agents, and you could potentially make their motor features worse. So look for that. When we're starting this medicine to treat motor symptoms, particularly in dementia with Lewy bodies, again, what we most often would look at is carbidopa, levodopa. That's pretty much the agent that we would recommend if you're going to use a medicine to treat the motor symptoms. The other medicines would be more at risk to cause side effect in this population. As I said, you want to be thinking about physical therapy, occupational therapy. It takes a team, and that's which makes our healthcare system so rich, is that we can offer other therapies as well. When we talk about the neuropsychiatric symptoms, which can often be the symptoms that can be the most difficult when somebody maybe less familiar with this disease thinks about how do I treat this? Because like I said, most of the medicines used to treat psychosis, delusions, hallucinations are contraindicated in this population. And so you have to be very cautious, and that's where this toolkit can be very valuable. Psychosis can include hallucinations, delusions, and they may warrant therapy, medications, they may not. You may think about non-pharmacologic approaches first, which can include orientation. I tell my loved ones, we talk about the toolkit for those care partners caring for those with Lewy bodies, the loved ones of those with the disease. And that toolkit is distraction. So if somebody is, getting agitated or irritated, try to distract, talk about something else. If somebody's hallucinating and it's getting upsetting, you can validate. Oh, I see that person. I told them to leave. Sometimes that's enough. And so non-pharmacologic approaches are important. But when that's not enough, and the symptoms are persistent and impactful, then we look to the medications. Cholinesterase inhibitors, which we talked about for cognition, can be helpful in hallucinations and delusions. And so it's something, because they're so well tolerated, I would like you to think about that first line when you can. Now, obviously, in the more emergency setting, somebody coming into the emergency room, because acetylcholinesterase inhibitors take time to work, you may not be reaching for that. You might be reaching for an antipsychotic, but the only antipsychotics that are safe to use are quetiapine, clozaril, and Nuplazid. You're most likely going to be reaching for quetiapine because it's just more readily available. You don't have to worry about monitoring blood counts, cell counts like you do with clozaril. Nuplazid is often not on formulary in most hospitals, and so again, it's not likely something you're reaching for first line. Something to keep in mind in the outpatient setting. And again, in the toolkit, you're going to see a nice general overview of general principles, talking about using cholinesterase inhibitors as first line. Again, going over those considerations that we talked about in the cognitive symptoms section. It's going to be repeated here in the neuropsychiatric features. So be aware, like I said, with antipsychotics, if I can stress one thing today, that's what I want to stress, is that most are not safe. Most are contraindicated. The ones that are safe to use are quetiapine and clozaril, and then pimavanserin or Nuplazid is, sorry, how you've heard me call it today by its brand name, but pimavanserin, the generic, is approved for the treatment of psychosis and Parkinson's. It's not improved, FDA approved in DLB, but you can consider it. Like I said, the experts will often think about using this off-label. This is just more on the actual symptoms themselves. So that's what's nice about the toolkit. It does give you information about the symptoms themselves as well. Depression and anxiety, apathy, while they don't fall under psychosis, they're under the umbrella of neuropsychiatric symptoms, and we do discuss the approach to management of these features as well. In general, with apathy, non-pharmacologic approach is, I say, you're going to pick your battles. You're going to motivate when you can. Gym buddies are important for exercise. There are going to be times where you're just going to, if your loved one doesn't want to do something, you're going to let it go. When medication is used, we will think about a cholinesterase inhibitor. I don't really, the reason is you're probably already using it for other things, but it may help with apathy, but you're likely using it to help cognition and hallucinations already. And then there is some evidence that may help with apathy. Depression and anxiety, if we're going to use a medicine, the first line is an SSRI. So think about, safe SSRIs, so ones that are, have less anticholinergic side effects. And we do go over that in our guidelines as well. And lastly, we're going to talk about sleep disturbances. We talked about REM behavior disorder being a key prodromal feature, something that can occur years before the onset of the motor and cognitive symptoms, but also during the disease course. There are other sleep disorders that can occur: excessive daytime sleepiness, restless leg syndrome, insomnia. Insomnia is a common sleep disorder in these diseases. Sleep apnea is disproportionately common in this population, so be thinking about screening for that. Have a low threshold. And here's REM behavior disorder. Again, this is something that we think to be one of the key features of these diseases. And we go through the guidelines to treatment of that. With daytime sleepiness, as with other symptoms we talked about today, think about pharmacologic and non-pharmacologic approach. Non-pharmacologic approach, you're going to be asking, about sleep hygiene and are you sleeping well? What's maybe impacting sleep? You might want to address that first. Are you getting enough exercise? Things like that. To promote wakefulness, rarely we might look at a stimulant, but again, that needs to be used with caution. These patients are at risk for side effects more than the general population. Restless leg syndrome. You want to, be cautious with this as well, because our patients are going to be more at risk for side effects from the medicines that we most often use for the treatment of this. So dopamine replacement and gabapentin, but a high degree of caution. Consider ferritin levels, checking ferritin. We know that actually having a higher ferritin, so iron supplementation with a higher target, can be helpful. So motor related sleep disturbances. So again, think about looking at their medications, maybe we have to change the formulation. Sleep apnea, be aware that this is common in this population, and so have a low threshold to screen, particularly when you hear about daytime sleepiness, particularly when you hear about frequent awakenings at night. And of course, the treatment for sleep apnea is CPAP therapy, which can be very effective. REM behavior disorders, that propensity to enact the dreams. Now, if this is occurring rarely and not causing any trouble, just maybe some yelling out, rare kicking of their partner, as long as it's not disturbing them, you might just kind of watch it. If it's becoming more persistent, more notable, God forbid, leading to falls out of bed, you want to be thinking about treating this. And our first line is actually melatonin. You start at a low dosage and titrate up gradually. In those who are not responsive to melatonin, we will look to second-line therapy with clonazepam, but you want to be cautious with that medicine because of the potential for side effects. Again, understanding those with Lewy body are more at risk. Advised, when I hear about insomnia and sleep fragmentation, sleep hygiene is critical. And so I'll often talk to my patients and I learn a lot about perhaps improper sleep hygiene, using screens. We're in a world today where we're, maybe instead of reading a book, we have our tablet and we're reading that way, but screens can be very activating and you want to avoid that before bedtime. So talking about those things, avoid anticholinergics. So, I often hear about Benadryl to help somebody with sleep. Our patients, the Lewy body patients, are very sensitive to anticholinergics. So it's best to avoid that. Melatonin, if needed. So if a medication is needed, melatonin is really our first line, and it can be effective. We do know that those with Lewy body are more deficient in melatonin, so often need supplementation. Caution with other sleep aids. And lastly, we're going to talk about the autonomic symptoms, so dysautonomia in our patients and our approach to that. There are different forms of dysautonomia, and this overall guideline, this overview that you'll see in the DIAMOND Lewy toolkit goes over those symptoms and our approach to management. Constipation being a big one. So firstly, think about increasing hydration, fiber, but then we do have recommendations for medications. Looking at orthostatic hypotension, which is an often disabling, so an impactful feature of this disease, that propensity for blood pressure to lower upon standing, and it can be difficult to manage, but we often, but we can manage this. We start with non-pharmacologic therapies. Again, increase water, maybe liberalize salt, take your time with position changes. But when a medication is needed, we do have recommendations here based on expert opinion. Urinary dysfunction. We often collaborate with a urologist who are really the experts in this symptom, because often more further look at what's going on. So like a urodynamic study may be needed so that you can best think about how to treat. We do think about botulinum toxin in our patients because there's less potential for systemic side effects. It's more localized therapy because, again, remember, our patients are going to be sensitive to the side effects of most of the medications we use. Erectile dysfunction is a common feature and something you want to be talking about because it can lend itself to poor quality of life. And so we want to be talking about and seeing how we can help with that. Again, everything with caution. The medications can lend itself to hypotension. So, and we already know our patients are at risk for orthostatic hypotension. Something to be counseling on and monitoring for. We have learned that we know that those with Lewy body are more susceptible to excessive sweating, and sometimes that's one of the early features that they describe. And so we have some recommendations on how to perhaps address that. Sometimes it is associated with the off state. When we say off, we're often referring to the motor symptoms, so the Parkinsonism. And off generally means when the dopamine levels have dropped, so maybe they're in between doses. And so you might want to be thinking about, if this is happening at the certain time of the day, maybe we need to add in a dose or make the interval between their doses shorter. constipation is a common feature of Lewy body, and can contribute to significant discomfort for our patients, and something we spend a lot of time talking about. And so first you want to look at what's maybe making things worse. Again, making sure I'm often talking about the importance of hydration. Hydration is critical. But when medicines are needed, we do have some guidelines here. Gastroparesis, like our patients, they have slowed gut motility, and so this can be a tough feature as well. So we often say maybe small, frequent meals might help with that, and then sometimes as you're optimizing their motor symptom management with levodopa, you can help with this as well. Orthostatic hypotension, we talked about, the pharmacologic and non-pharmacologic approach. So, and we have that outlined here. And that is the end of, going through each of the symptoms that we've outlined in our toolkit. And I encourage you to go, look at it, pull it up when you need it. It's an incredible resource that we're hoping will really help as you manage these patients, because it is so nuanced. So key takeaways are that, patients with Lewy body are sensitive to medications in general. And so we've tried to really outline the cautious way to introduce medicines when they're needed, the medicines we would recommend, based on understanding how sensitive our patients are. And that's what this toolkit really goes over. Always keep in mind that there's pharmacologic and non-pharmacologic approaches. Sometimes the non-pharmacologic approach is the approach that's most indicated in that situation. And a key takeaway is that most antipsychotics, in most situations when you're thinking about the approach to management for psychosis, hallucinations, delusions, you have to be very cautious. And really the ones that you're going to grab first, if you need an antipsychotic, are quetiapine and clozaril, and pimavanserin as well. Those are the only three that are safe to use. All other antipsychotics are not safe and potentially could be fatal in our patients because of their inherent dopamine deficiency. Keep in mind, acetylcholinesterase inhibitors like donepezil, rivastigmine, galantamine can be helpful for hallucinations and delusions and are in general well tolerated. So thank you so much for your attention, and I hope this was helpful. And again, I encourage you to go to our LBDIA Association website and Google our US-based Diamond Lewy Toolkit, which was adapted from the UK's amazing resource, Diamond Lewy. Thank you so much. Bye-bye.